So lower GI bleeds, we're looking at a hematochezia. We're looking at coffee ground, but black tarry stools. And again, hematochezia is a risk factor for a upper GI bleed, right? About 10% of our bright red bloods per rectum, or if you're fancy, a hematochezia, 10% of those can equal a upper GI bleed. All right, so we'll talk about a few different upper GI bleed reasons, right? We'll talk about recap on lower versus upper GI bleed, and what look at diverticulosis, diverticulitis, look at ischemic colitis, mesenteric ischemia, and some of the other causes of a lower GI bleed, right? So lower GI bleeds are not as serious as a upper GI bleed, but except the asterisk is when it is a 10% reason for an upper GI bleed, right? It can be going through the GI tract super rapid from whether esophageal varice or really bad ulcer that can make it all the way out to and go with rapid transit through the GI tract, right? So here's an example of rapid transit as well.
Life is good! This is fun! My anus is bleeding! My anus is bleeding! For the love of God and all that is holy, my anus is bleeding!
So lower GI bleeds can be pretty fast, pretty quick. All right, so a brisk upper GI bleed can mean can be hematochezia, right? 10% of those equal a upper GI bleed, which you just talked about in the previous section, right? So first rule of GI bleed is what? Is to check if it's a upper GI bleed, right? So if it's a lower GI bleed, could be an upper. So that's the first thing we should be considering, right? So we're focused on this section is everything lower than a ligament of Treitz. That's what kind of distinguishes upper versus lower, right? The anatomical structure right there. It kind of holds up the duodenum. Okay, so what are signs of lower GI bleed? As we mentioned, you have melena, you have and hematochezia. Those are the two ones we're going to be balancing, right? So it could be black tarry stool or melena. Could be making its way all the way from the right colon over. That could be a reason for melena, but most commonly melena is from a small bowel, or sorry, from an upper GI bleed of some sort. Okay, that's most common with melena at least. And hematochezia, again, it could be a bleed that's from the diverticulum. It could be a bleed from like ulcerative colitis. It could be a bleed from a tumor of some sort. It's a quicker, more proximal bleed to the rectum at least. Okay, and then how can you tell the difference between upper and lower GI bleed, right? So hematemesis is never a lower GI bleed. It's really talented to vomit blood that's developing in your diverticulum. All right, that's going to be to go through 35 feet of tube to vomit that up. That is very difficult to do, all right, and not possible because there's three sphincters. You got a sphincter here, you got a sphincter at the pylorus, you got a sphincter at the lower esophageal sphincter, you have an upper endoscopy or upper GI sphincter, esophageal sphincter, and you have your mouth, which is a sphincter as well, right? So that's really hard to do. And then what else? So upper GI bleeds have hematemesis, and they have a what else? What are the symptoms upper GI bleeds have? And for upper GI bleed, you can vomit blood or you can vomit coffee ground emesis, right? And yes, upper GI bleeds can have hematochezia as well, 10% of the time, right? So it's 10% right there. And then what else? So upper GI bleeds, they have that BU and creatinine change. A lower GI bleed is not going to have that time for you to digest if you have a bleed over here, the time it takes to go from here to here is, maybe 2 hours tops if it's a really slow bleed. So, but if it's in the small intestine, it has about 10 to 14 hours to marinate, right, and ferment and kombucha, and it's able to then be tarry and stinky, right? And also you have time to break it down with your what enzymes? Your pancreatic enzymes. Pancreatic enzymes are what break down proteins. So where do you secrete pancreatic enzymes at? All the way up here. That's that little duodenum, little sphincter of Oddi. Your pancreas secretes, your pancreas to come behind there, secretes it right into that duodenum to break down proteins. Are you going to break down proteins in your distal gut? No, that's not going to happen. So when you break down the proteins, you absorb the proteins, and your body will package them together and say, hey, I don't need as much protein. Let's package this as waste products, and that waste product is BUN, right? So BUN creatinine ratio that's high, more than 30 to 1, is a sign of an upper GI bleed, not lower. Okay, so that could clue you in too. Someone comes in, they got hematochezia, and the BUN is 60 and the creatinine is 2. Is that greater than 30 to 1? What's 2 times 30? 60, right? What's the creatinine? And 1 was the 2, right? So that's greater than 30 to 1 or 30 to 1 plus, right? So that's a sign that I have an upper GI bleed for that hematochezia. But the BUN is 40 and my creatinine is 2. That's a relationship of 20 to 1, right? So 1 being the 2 times 20, 40, right? So BUN creatinine ratio is a good way to figure out if it's upper or lower GI bleed, right? Other risk factors you can look at, right? So looking at history is very important in the GI world. So tell me how this started, right? It's like, oh, I take ibuprofen. I took like 5 pills yesterday, and then I've been taking like 3 pills every week, and I just had to come in today because the pain was so bad. But they don't even tell you the pain's bad. They just tell you that the pain was bad this morning, and I started vomiting blood. Whoa, that means it might have been NSAID use that caused your GI bleed today, right? H. pylori, right? They might have a history of H. pylori, but it could be ulceration, right? They could say with meals, they really get a lot of epigastric burning, gnawing pain that occurs, right? Hiatal hernia, they'll know they have a hiatal hernia. They have really bad breath. They vomit globuses of food. They're really fun at parties. And then we have, what else? They have lower GI bleeds, right? So lower GI bleeds, distal that ligament of Treitz, and that's going to be your hematochezia without the upper GI symptoms. But we always have to worry that it might be a brisk upper GI bleed. If you have blood clots in the stool, it is not upper GI. Those things don't mix, right? Blood clots means that blood has had time to gel, right? If it's coming super fast from the upper half, does it have time to gel? No, it's just making its way down a little slow trickling stream, a little babbling brook. Okay, you have a hemodynamic instability. That's usually a upper GI bleed. So this is refuting factors. You have a unstable patient, it's usually an upper GI bleed. That's why we kind of put a lot of emphasis on upper GI, right? If you have a lower GI bleed and they're hemodynamically stable, that's probably a lower GI bleed. If they're hemodynamically unstable and a bright red blood per rectum or hematochezia, that is a what kind of bleed? A upper GI bleed, right? So BUN creatinine ratio is high after GI bleeding. And again, when you have hematochezia, it can be bright red blood per rectum. I forget why he's running. It's going to cause blood itself is very, very irritating. That's why you vomit. But also you're going to have a very, very profound diarrhea of this blood as well. All right, so blood and stool. So if you take a little swatch over to Home Depot, there's different colors of red you're looking for. You're looking for maroon, you're looking for bright red, you're looking for tarry or dark red. So there's all kinds of different levels of GI bleed, right? Melena is our black, tarry, sticky stool, right? If it's black, tarry, and sticky, it is a GI bleed. If it's black stool, it is not a GI bleed. It's just iron supplementation, right? I just have iron pills, and that's what caused it to be black. The other distinguishing factor is diarrhea. Diarrhea is obviously going to be more liquidy, yes, sticky and tarry, but a black stool from an iron patient, iron is very what? Very, very constipating, right? You don't have constipation with GI bleeds ever, right? That's not a thing, right? Blood is very, very irritating the GI tract. Your GI tract is going to start going to increase peristalsis really, really quick, okay? So you got melena, that's your black, tarry, sticky, shiny stool. that is going to be, it means it'll stay in the GI tract for about 7 to 14 hours and oxidized, doesn't smell great, right? And it's about 60 mLs or less of blood that you're pooping in the 10 to 14 hours. If it's more than 60 mLs, it's going to start turning maroon. It might even turn bright red blood per rectum, especially if they start getting higher up in the GI tract, right? So 60 mLs usually are cut off that they've found. All right, if it's black and non-sticky, it's iron, someone that likes chocolate, chocoholic, right? Or they have a licorice, usually black licorice, right? Because licorice comes in many different colors. So black licorice and iron being the most common. I haven't seen many chocolates. I guess if you really like dark chocolate, I don't know, go in the town with the dark chocolate, that might cause some black stool, and that's going to be not going to be sticky. It's going to be a more constipating, more less stinky also stool. Okay, so hematochezia, as we mentioned, that's our bright red blood per rectum. Our BRPPR sounds like a radio network, right? So welcome to BRPPR, and we're here with your weather forecast today, right? So it's going to be a chance of black sticky showers, right? That's a sign of melena, right? So NG lavage is usually a good thing to do. If someone has a bleed of any sort, lower or upper, is to throw an NG tube in to see what is going on, right? If there is no output, if they have no, you have clean output, you have like a bilious output out of the stomach, it's not a GI bleed. 100% not a GI bleed. But if you put that G tube in or that NG tube in, and you start getting coffee ground, well, shoot, that might be an upper GI source, right? So it's a way to figure out if someone has a upper GI bleed, is to throw an NG tube in anytime someone presents with GI bleed. Okay, and there might be some naysayers say, oh, you can't put an NG tube in or a G tube in. It might make the ulcer worse. There's no evidence of that. That's just like some expert opinion as someone had like in the early 80s. Hey, we should have put NG tubes in with the GI bleeds. Right? Doesn't worsen a GI bleed when you put an NG tube in. All right, there's no documented evidence of that. And then painful. So is it a painful lower GI bleed? Because there are painless GI bleeds. But ischemic colitis is very, very painful. Inflammatory diseases like Crohn's and ulcerative colitis are very, very painful, and they present with GI bleeds as well, right? Where your belly pain is it left lower quadrant or right lower quadrant, right? Is it a left upper quadrant or is it epigastric? These can tell us where the bleed is and if it is bleed. All right, and hemorrhoids are visible on physical exam, so they have usually red streaks in the stool, but it might be bright red blood per rectum as well if it's a internal hemorrhoid, and that can be a reason for a GI bleed, right? Or a bright red blood per rectum if they have a bleeding internal hemorrhoid. And then we have anal fissures, which can happen commonly with ulcerative colitis as well. But then that's painful GI bleeds. What about painless GI bleeds? Like I mentioned, diverticulosis is a GI bleed of some sort, and it usually presents with left lower quadrant area, but is it painful? No, it's a painless GI bleed. Diverticulitis is painful, but a GI bleed, it is not. So diverticulitis has no GI bleed associated with it. Okay, diverticulosis is the bleeding one. All right, so then colon cancer. Colon cancer does not have pain, right? People don't seek out medical help when they have bright red blood per rectum and they're losing weight over the last 3 months, and they have this iron deficiency anemia. They're very weak and fatigued all the time. They don't seek out help because it's just not painful. The only time it is painful with colon cancer when it starts pushing on other organs, right? It might have some constipation, and they might have a lot of discomfort when the mass gets to the point where it actually starts compressing things. But if they just have like a polyp that is bleeding and oozing, that's not going to cause any pain. Polyps are painless. Okay, and then varices. Do varices hurt? Absolutely not. They don't hurt at all. Esophageal varice, gastric varice, a rectal varice, which is what we're talking about here, rectal varice. We're talking about lower GI bleeds, right? Because varices can happen on both ends, upper and lower. But a varice of any variety is not painful. It does not hurt when you have a variceal bleed, right? It might be uncomfortable when you vomit. It might be uncomfortable to have diarrhea all the time, but it doesn't hurt at all. It doesn't burn, doesn't gnaw, doesn't radiate, nothing like that. Okay, and then what else? If you have beets, right? I've been guilty of this, right? So it looks like a murder scene afterwards. So we intake beets, beet juice. You go on a health kick. It's like I'm gonna get beets all the time. It's like, oh shoot, it's too late. I'm not got a GI bleed, right? That was the beets. It wasn't any kind of nefarious, any kind of GI bleed or anything like that. right? As we mentioned, clots per rectum, that is really telling you it's what kind of bleed? If clots per rectum, that's a lower GI bleed, right? So what is an upper GI bleed? You got the BU and creatinine that's elevated. You usually have a history of alcohol use. Usually a younger patient has a higher risk of upper GI bleed. You got a cirrhotic patient, cirrhosis patient, that is definitely someone that's pretty high risk for an upper GI bleed. I just said, yes, it can cause rectal varices, but that's quite uncommon. Okay, more common it'll hit the esophagus or the gastric for variceal bleeds, right? NG lavage is good to assess if you have a what? A upper GI bleed, right? If I do a lavage of with an NG tube and I see coffee ground or I even see bright red, that's, oh shoot, I need to have the GI team come in and do an upper EGD, right? An upper GI endoscopy. If it's negative, right, that means that wasn't a GI source, or upper GI source, I should say, okay? And then we might need to see, is there somewhere along the GI tract, the 30 feet of GI tract, where is it bleeding? It might be oozing somewhere along that GI tract. So we might have to do a test to see if it's oozing at greater than 0.5 mLs per minute, or even 0.1 mLs per minute. So there's CTs we can do. There's RAD tests we can do as well, which take a long time. They're super fuzzy, right? But there's angiography to assess where the lower GI bleed might be in the system. And once we do know where it's at, we can go in there with a catheter and we can embolize it, just like we do with a cath lab or like for a heart attack, right? We go in there, we open up the vessel. You obviously would not clot the vessel. But if you have a bleeder, right, anywhere in the body, we can go with interventional radiology, and they can go in, they find the bleeder, and they can clot it off so it stops oozing. Okay, so what else? So 7 to 14 hours is melena. Non-sticky stools is usually iron, right? Bismuth salts, I guess, but black licorice. We got red blood in the stools. It might be hematochezia. If it's blood streaked, bright red blood, it's classically a hemorrhoid. That's a classic hemorrhoid symptom. And then what else? So it's non-bloody, but you have beets. That could be a reason for a lower GI bleed. But it's a lower GI bleed? No, it's just beets.
911, where's your emergency?
There's blood everywhere.
That sounds very grisly. Sir, just going to ask you a couple questions. Have you had any trouble urinating?
No.
Do you have any new sexual partners?
No.
I need to know what you had for dinner this evening.
A salad.
Could there have been beets in the salad, sir?
There's spinach.
Was there goat cheese?
Oh, yeah, actually, there were beets in there.
Yes. Beets often change the consistency and the color of your stool.
Really?
You're going to be fine. I promise it's not blood, it's beets.
Oh, damn. Okay, thank you.
You're very welcome.
All right, so beets.
For that NG lavage, do you need an order for the NG tube? Or is it
Well, you need an order for everything technically. So the NG lavage is something to expect after a GI bleed, right? That's something that you would, you prompt, say, hey, should we do an NG tube to see if it's upper or lower? That'd be something to assess, right? So yes, everything does need an order. All right, so speaking of orders, CT angiography or a tagged RBC scan. So we can do a tagged RBC scan, or labeled RBC scintigraphy. All right, so this is where you're tagging the RBCs. Right, you give a little injection of irradiated RBCs. You take some of the patient's RBCs, you add a little secret isotope, and then they mix, and then you inject it back in the patient. And they then look at serial scans, and they see if there is a little oozing. And it's literally this fuzzy. It's really, really hard to tell what might be oozing. Okay, so they tag it, and if it's bleeding at 0.05 to 0.1 mLs per minute, then they can say, oh, they'll see it on the scan. If it's bleeding less than that, they're not going to be able to see it, right? How many scans have been positive in the past 5 years? 5, right? So they are very, very, I guess the literature says it's reliable, but it's not easy to see. The better option is a CT scan, right? So you do a CT scan, you give a bolus of contrast, and then you do 3 different stages of a CT scan. You're not doing just like one shot. You're doing 3 different CT scans. You can easily see if they are bleeding or not. A 3-phase CT scan. The unfortunate thing is they have to be bleeding at the time of the scan. Same thing with a RBC scan. They have to actively be in the CT scanner, pooping blood for you to be able to see this at all. Okay, so they have to be pooping the whole time. No, we can put a little cork in it, but we can, they have to be oozing the whole time during the CT scan while the contrast is going for you to be able to see the blood from bleeding, right? To see the bleeding vessel that might be the culprit, right? And then once you find the culprit, they can go in with IR to intervene, right? Interventional radiology can go in and embolize that vessel that might be oozing, right? Whether it be it could be, I guess, ischemic colitis, but it could be like a diverticulosis bleed, it could be a colon cancer bleed, it could be any kind of bleed that we'll be talking about that cause lower GI bleed, right? So it's better than a tagged RBC scan, this 3-phase CT scan. And again, hopefully we can embolize it if need be, but it often misses the bleeds when the patient stops bleeding. So like you trim on the side and you like self-tamponade the patient, and now your scan's negative. So they take it back to the ICU, and they start bleeding everywhere, like like two chucks worth all the way down to the toes of blood. And it's like, well, the CT scan was negative. It's like, well, no, I see this patient actively bleeding. My shock index starts going up. I start seeing things that will then encourage us to get more action. Okay, so it becomes positive when a patient is bleeding only. That's with our tagged RBC and with our CT scanners. All right, so what else? So indications, again, you do this when you have a stable patient and we're trying to figure out where the bleeds happen. We know there's bleeding, right? The nurse called and say, hey, they're bleeding down to their toes, and we're going to do a scan to see if there's something that can be done with IR, for instance, right? If not, then what's the next step is to do a endoscopy, right? A colonoscopy or an endoscopy. Okay, we have options, basically, is what this is kind of pointing to. A 3-phase CT scan can detect about 0.35 mLs a minute of bleeding. Okay, it's very, very sensitive for a active bleed, right? For a obscure bleed or bleed where we don't know it's bleeding, it's not bleeding actively right then, it's like a flip of the coin whether it's accurate or not. And the other ones are not anything better, okay? But it is better than the other ones, or I guess it's kind of tied with endoscopy. All right, so that's how you do other studies we might do besides endoscopy or colonoscopy. All right, so lesser causes. We're going to summarize on one slide lesser causes of GI bleed, and then we'll get into more detail about diverticulosis, ischemic colitis, mesenteric ischemia, and such. But these are the ones that don't fit on the other slides. All right, so colorectal cancer, about 15% of our lower GI bleeds. That's where I have a cancer anywhere in the colon or the rectum. That's why it's called colorectal cancer, and it is bleeding, slowly, right? Polyps don't bleed profusely; they ooze over time, and they keep oozing and keep oozing and keep oozing, and they can get anemic, right? So iron deficiency anemia is common with a colorectal cancer patient. They have iron deficiency anemia, they get fatigue, they get tachycardic, they get dyspneic on exertion, that they're very, very anemic. Also, the classic sign are red flags, right? Or I think they call them warning signs, right? Warning flags. They got red flags where they have weight loss. Weight loss and signs of lower GI bleeding, that is a red flag for colorectal cancer. All right, so then we have cirrhosis. Only 5% of our lower GI bleeds, or upper GI bleeds is like up to 20%, right? But lower GI bleeds, it could be a rectal varice that is bleeding, right? So when we talked about upper GI bleeds, our portal circulation was taking all this blood from the GI tract and the splenic system and the gut. Is all uploading all this stuff through the liver, right? And when we have cirrhosis, the liver is now a high pressure system. It's really hard to get stuff through that liver, and the portal circulation has to work overtime to push the fluid into the liver, or the blood into the liver, right? And then now once that happens, that's going to increase the portal circulation's pressure, or it's going to cause portal hypertension. And that could cause a rupture of vessels in the esophagus or the gastrum, or it can come all the way down here to the rectum and bust through the variceal bleeds in the rectum. It doesn't bust through just like, oh, it's Tuesday, time to bust through. No, it does that with infection. Right? When you have an infection, your vessels are more leaky, and therefore they are more prone to oozing. Now, once you've started that leak with this high pressure system here, it's going to keep oozing and keep oozing and keep oozing. Okay, so that's the idea. So here's some example of rectal varices. Those guys are super, super engorged with blood. They're ready to pop once you have an infection present. Okay, so we have this, and when we over resuscitate, what's going to happen? All that fluid we give them, right? We gave all the volume of blood to the patient, and then it goes to the heart, and the heart then pumps it to the kidneys, and the kidneys then pump that blood, or to the whole system. All that blood gets pumped to the spleen, gets pumped to the gastrum, gets pumped to the, I guess, skin too, and the GI tract. That's arterial blood, right? And then what's the venous circulation? That is portal circulation. Now the portal circulation is because you're just adding blood to the party, right? So that's not what we want to do. So when we give packed RBCs, for instance, or we give FFP, all that blood that we gave as an infusion on the venous side is going to make it to the heart. The heart's going to pump that blood to the spleen, and the spleen's going to take that blood to the capillary system and dump it into the portal circulation. All the mesenteric circulation you provided blood with is going to then take it to the arterial system, the capillary system, and now dump it into the venous portal circulation, right? Same to the spleen, same to the esophagus, stomach, etc. So all that fluid that you're giving them is just going to make these veins more and more engorged. So the idea is not to over-resuscitate, but to then make sure we are get them scoped as soon as possible. When they have a rectal varice, it is very, very uncommon, but it's something that we have to be alert to, right? And we don't over-resuscitate. We can tolerate soft BPs. We'll allow blood pressure 95. That is cool, right? So we want that blood pressure to be on the lower end, because if it's on the higher end, you're going to be pumping more blood to all the GI system, and that will then dump into the portal circulation. And then coagulopathy is a reason for a lower GI bleed, just like upper GI bleeds. Okay, and we give reversal agents for these, right? Reversals. Okay, so PCC, reversals, right? PCC is usually our go-to agent if it's like a significant bleed. Otherwise, if we want to fix it tomorrow, vitamin K. If we want to fix it in 4 hours, FFP is fine. Okay, to reverse those things. And aspirin use, NSAID use can damage the stomach, but can also damage the lining of the lower GI tract as well. They got a history of lower GI bleeds. That's probably a risk for, you probably have a lower GI bleed on your hand. And we kind of touched base on Crohn's disease and ulcerative colitis. Those present with bleeding diarrhea as well, right? Crohn's disease usually presents with iron deficiency anemia and more malabsorption, more thinner patient because they are not absorbing nutrients via the small bowel. Crohn's disease affects the small bowel, whereas ulcerative colitis is itis of the colon, right, or the colon only. And then we got hemorrhoids. So that's about 20% of our bleeds. So a lot of patients will complain of bright red blood for rectum, and it's just hemorrhoids, which is good because hemorrhoids are never life-threatening. No one died of hemorrhoid, right? That's not going. You're not going to get hemodynamically unstable from a hemorrhoid. It's like, but is a hemorrhoid the same as a rectal varice? They're different, right? Rectal varice is increased pressure that's just going to pop, and it's going to start bleeding and bleeding and bleeding and bleeding, right? It's not going to stop until we fix it. Whereas a hemorrhoid is a trapped blood vessel that has become engorged. So you have an engorged blood vessel because we are doing what? What causes hemorrhoids? We're not a subscriber to the Squatty Potty, so we have a lot of constipation in our lower GI tract, and it's more pressure, more pressure, more pressure, more pressure, more pressure, pop, right? And you've got a poppage of vessels or veins. Yes, these are veins too, right? And the rectal varices, but these varices down here pop, and they become irritated, and they start clotting off, and they start opening up, and now they're painful. And so it's like usually painful defecation is associated with it. It's due to this clotting off of the vessel, but also comes trapped. So stage 4 is like a trapped vessel where sometimes it might just poke its head out like that, whoop, 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 and it might get occluded, and then the GI doctor is going to just push it back in like a hernia, whoop, and then their pain is resolved. But if it's a stage 4 hemorrhoid, they go in there and they just band it off just like our varices, right? And then the varices just falls away. Okay. Usually these guys get a lot. They'll get that excised or banded, and these guys have a lot of pain, a lot of discomfort, a lot of itchiness. So there's a lot of agents for that, right? Is it painful GI bleed? Yeah. Is it as painful as a diverticulitis, which is not a GI bleed, but is it as painful as ischemic colitis or mesenteric ischemia? Absolutely not. Those things are extremely painful. Hemorrhoids are very, very uncomfortable. Again, no one died from a hemorrhoid. Okay, so we have rectal varices, we have esophageal varices, and splenomegaly. These all happens from cirrhosis, from high portal hypertension, which we'll talk about more when we talk about cirrhosis. But that's a different situation compared to a varice. Are they both the same veins that got engorged? Yes, but one became entrapped, clotted off, ruptured, and the other one has poked through because of a sepsis process or a SIRS process, for that matter.